Welcome to LexCura Clinical Insights, the podcast where clinical evidence, healthcare standards, and litigation strategy come together. I'm Michelle Carroll, founder and chief clinical strategist of LexCura Summit. The CMS conditions of participation form the federal regulatory foundation for home health agency operations. They address patient rights, care planning, coordination, clinical record requirements, aid supervision, quality oversight, and infection control. When an agency fails to meet these requirements, the issue may extend beyond an isolated clinical error. The regulatory failure can provide an additional layer of evidence showing that the agency's systems, policies, or oversight did not meet required standards. Survey deficiencies, inspection findings, compliance records, and other CMS data can help reveal patterns that may not be immediately visible in the patient chart. In this episode, I will explain how to identify relevant CMS compliance records, compare them with the allegations in the case, and use regulatory evidence to strengthen the clinical negligence analysis. Okay, so here's something wild. There's a publicly accessible database that can completely change how attorneys approach home health litigation, and most of them don't even know it exists.
Oh, really? That's just surprising. What kind of database are we talking about?
It's called CASPER, and it's part of the CMS system. It's essentially a treasure trove of compliance data for every Medicare certified home health agency in the US. We're talking deficiency citations, survey histories, complaint investigations, you name it. And the kicker, it's free and available to anyone.
That's incredible. So you're saying attorneys could use this data to strengthen their cases without even needing a subpoena?
Exactly. And that's just one piece of the puzzle. Today, we're diving into how the CMS conditions of participation, or COPS, can be used to build stronger liability cases in home health litigation. These aren't just bureaucratic rules. They're enforceable federal standards that set the minimum bar for patient safety.
And when agencies fail to meet those standards, it's not just a compliance issue, it's a potential goldmine for litigation. Let's start with the basics. What exactly are these conditions of participation?
The COPs are federal regulations under 42 CFR, Part 484. They outline the minimum clinical and operational standards that Medicare-certified home health agencies must meet to operate and receive reimbursement. Think of them as the baseline for patient safety and quality care.
So these aren't just recommendations or best practices, they're actual legal requirements?
That's right. And when agencies don't meet these requirements, CMS has the authority to impose penalties, require corrective action plans, or even terminate their Medicare certification. For litigation purposes, these COPs provide an objective standard against which an agency's conduct can be measured.
And that's where it gets interesting. If an agency's actions fall below these standards, you're not just arguing clinical negligence, you're arguing a regulatory breach.
Exactly. And that's a huge distinction. Most attorneys focus solely on the clinical standard of care argument, which is valid but subjective. It often boils down to a battle of expert opinions. The regulatory argument, on the other hand, is black and white. Either the agency met the standard or it didn't.
Let's talk about some of the key areas covered by these COPs. What are the most relevant ones for litigation?
Some of the most litigated areas include patient rights, comprehensive patient assessments using OASIS, plan of care development, skilled nursing and therapy services, home health aid training and supervision, clinical record accuracy, quality assessment and performance improvement, or QAPI, and infection prevention and control.
That's a pretty broad range. And each of these areas has specific detailed requirements, right?
Absolutely. For example, there are rules about how often supervisory visits must occur, what needs to be documented in a plan of care, and how infection control protocols should be implemented. When an agency fails to meet these requirements, it's not just a clinical lapse, it's a violation of federal law.
And that's what makes this so powerful. You're not relying on subjective opinions, You're pointing to an objective standard that the agency failed to meet.
Exactly. And when you combine that with the clinical argument, you're creating a layered case that's much harder to refute. You're not just saying, this nurse made a mistake. You're saying, this agency was operating below the federal minimum standard, and that systemic failure caused harm.
Let's circle back to CASPER for a moment. How exactly can attorneys use this database in their cases?
Great question. CASPER stands for Certification and Survey Provider Enhanced Reporting. It's a CMS database that contains survey and certification data for every Medicare-certified home health agency in the U.S. This includes deficiency citations, prior survey history, complaint investigations, enforcement actions, and quality indicator data.
And all of this is publicly accessible?
That's right. You can access it through the CMS Care Compare website or directly through the CASPER portal. It's an invaluable resource, especially before you even file a case. You can pull the survey history for a specific agency and look for patterns of deficiencies that align with the issues in your case.
So let's say you're working on a case where a nurse failed to escalate a significant clinical change to a supervising physician. How would you use CASPER data in that scenario?
First, I'd pull the CASPER survey history for the agency. I'd look for any deficiency citations related to communication of clinical changes. If the agency was previously cited for failing to ensure that nurses escalated significant changes, that's a pattern. It's no longer just about one nurse making a mistake. It's about an agency with a known problem that failed to fix it.
And that pattern-based argument changes everything. It strengthens the case, expands the scope of discovery, and potentially increases the value of the claim.
Exactly. It also positions the agency's conduct as systemic rather than isolated, which can be compelling for a jury.
Let's pivot to another underutilized area, QAPI. This is one of those COPs that can be a goldmine in litigation, but is often overlooked.
QAPI stands for Quality Assessment and Performance Improvement. It's a federally required internal monitoring program that every Medicare-certified home health agency must maintain. Agencies are required to monitor quality indicators, identify performance problems, implement corrective actions, and evaluate the effectiveness of those actions.
And all of that internal data is discoverable in litigation?
Exactly. When you request QAPI records, you're asking for the agency's own documentation of its performance failures. If the agency identified a problem, say missed visit documentation or medication management, and documented it in their QAPI records, and then a patient was harmed in that same area, those records become evidence of institutional awareness.
So the agency knew there was a problem, they were required to fix it, and they didn't. That's a powerful narrative.
It is. And in jurisdictions where conscious disregard of a known risk is the standard for punitive damages, QAPI records can support a punitive damages theory.
Let's circle back to the big picture. How do you put all of this together to build a regulatory overlay argument in a case?
It starts with the clinical record. Identify the specific clinical failures, missed escalation, inadequate plan of care, supervision gaps, whatever they may be. Then map those failures to specific COP requirements. Next, pull the CASPER record to see if there's a deficiency history in those areas. If there is, you've got a pattern. If there isn't, you still have a regulatory violation.
And then you layer the arguments, the clinical standard of care failure and the regulatory compliance failure.
Exactly. It's a layered argument that positions the agency's conduct as a systemic failure, not just a one-time clinical error. And it gives you two evidentiary tracks, the clinical record and the regulatory record.
That's such a robust approach. Any final takeaways for attorneys who want to start using the regulatory overlay in their cases?
First, pull CASPER data early. It's free and invaluable. Second, map clinical failures to specific COP tags. Specificity is key. Third, include QAPI records in your discovery requests. And finally, use the regulatory argument to set the liability floor and the clinical argument to build the causation ceiling.
It's a game-changing strategy for home health litigation. Thanks for breaking it down so clearly.
My pleasure. It's a complex topic, but once you understand how to use these tools, they can make a huge difference in your cases. Looking forward to diving into more topics like this in the future.
Same here. Until next time.
Thank you for listening to LexCura Clinical Insights. CMS compliance records should not be reviewed in isolation. Their value comes from connecting the regulatory requirement to the agency's documented conduct and then to the patient's experience. The analysis should consider the applicable condition of participation, the nature and timing of any cited deficiency, the agency's corrective action, the patient's plan of care, the clinical records, and the harm alleged in the case. A regulatory citation does not automatically establish causation. However, when the same operational failure identified by regulators also appears in the patient record, it may support a broader argument involving notice, deficient systems, inadequate oversight, and repeated non-compliance. That is how regulatory information becomes meaningful litigation intelligence rather than background material. For more clinical intelligence, litigation analysis, and practical guidance, visit LexCura Summit at lexcurasummit.com. I'm Michelle Carroll. Thank you for joining me, and I'll see you in the next episode of LexCura Clinical Insights.